Dr. Shrinivas JOSHI, a prolific VR surgeon from Hubli, Karnataka, and he'll show his wonderful videos on macular holes, case-based use of flaps, grafts, and other adjuncts.
Good morning, everyone. At the outset, I would like to thank AIOS and Dr. Vishal Agarwal for including me in his IC. I think this is a successful fourth or fifth instruction course running, and it's been quite successful. So I'll be speaking about the flaps and the grafts in the macular holes. So coming to directly, I'll jump to the videos. If you can see here, this is the first what many people have described it. We described it like a petaloid fashion, especially in the extra large macular holes, not in very just large macular holes, but in extra large macular holes. So what's the advantage? It's like a flower petal pattern. Even if one flap goes off, the rest of the flaps will still remain. If you look into the earlier description done by Dr. Navroki, there is a quite significant amount of flap dislodgement which happens in these kind of cases. So to avoid that, and if you think that the flaps are too large, you can just trim it and then try to just stuff it inside. So it usually gives a good results. So then do a careful fluid air exchange, and then you can see the post-op there is a type 1 Mac hole closure. Now coming to the next set is, if you think that okay, this is the flaps might keep coming outside, then nowadays we have started using under PFCL. Under PFCL, the advantage is the flaps get stuffed inside the Mac hole. So the flap dislodgement is almost zero in any of these cases. So as you see here, I'm just trying to pull the flap in the similar fashion where I showed in the previous video. But the only difference here is it is done under the PFO. If you have IOCT, just to show that how the flaps cover up the macular hole, and then do a careful fluid air exchange, and then you can either use the gas or the oil tamponade based on the patient criteria. So we just published it, the surgical outcomes of petaloid multilayered inverted almost around 103 eyes in especially extra large macular holes, and the average mac hole size in ours were more than 800 microns MLD. So there was a 92.2% of eyes with type 1 closure. So coming to the next is the temporal flap technique, which is also quite successful. But the only thing is the compliance with the patient positioning is very, very important here. Otherwise, there are chances that this might fail. So it's not a very difficult or challenging surgical maneuver. It's pretty easy. You just have to take the flap from the temporal area and then just try to cover it up, and then do a careful fluid air exchange on the disc side so that the flap still keeps remaining folded. So coming to the next, what's the advantage? It's decreased incidence of downfill has already been reported with the technique of the temporal flap technique. Now if you see the classic ILM versus temporal ILM, the temporal inverted flap in fact has a 60% of EZ and the ELM rate restoration. Now coming to the next technique is in case where there is no ILM at all, there's a failed Mac holes, then how do we proceed further? So this was again a case of failed Mac hole where you can see the edges of the ILM has already been peeled large enough. There are various ways. You can either put a viscoat inside the Mac hole so that the flap stays inside the macular hole area, or you can just put a PFCL and then slide these sheets. The only difficulty under PFCL is the sheet might not come as easily as without PFCL. As you can see here, there is no counter pressure. If you put PFCL, then there can be a counter pressure. So you can easily peel it from the temporal area and then just try to stuff it inside the Mac hole, because the viscoat will be holding these ILM flaps. And this is the post-op vision, and there is a good type 1 recovery in these set of cases. Now coming to the next technique is the macular hydrodissection technique, which was again recently also published in the International Journal of Retina. So I'll be just showing here how do we do it. Here we use a 41 gauge cannula and just try to induce a macular detachment. Some people call it as a macular hydrodissection technique, some people call it as macular detachment induction technique. So various technique, but the technique is same. just you have to induce the detachment in all the three sides. Avoid detaching the retina over the papillomacular bundle as it might injure it. But make sure that the fluid wave passes out through the mac hole. The whole intention idea here is to lyse the 360-degree attachment of the edges of the macular hole which is stuck to the RPE. That is what is hypothesized. So these cases usually work well in type 2 closure where there is a flat closed mac hole, no, so a flat open mac hole where the edges of the mac hole are really stuck. So if you see here doing a fluid air exchange, you need that bullosity to come to the center and detach the edges of the macular hole. So this is the pre and the post-op. Out of my 5 cases, 3 have been successful and 2 have not been successful. So what's the mechanism of action? The injection of subretinal BSS reduces the tension and the stiffness which is intrinsic to the retina, and it separates the tight adhesions of the retina and the RPE. But however, we must ensure that the retina RPE adhesions completely lysed 360 degrees around the macular hole. Now coming to this next technique is the neurosensory graft technique, where I'll be showing the 2 or 3 cases. Here after doing vitrectomy, just try to cauterize the area which I wanted to. Usually try to choose the area where there are no blood vessels, and then try to little bit induce a detachment because you don't want to cut the RPE here. So here you can either do a unimanual or the bimanual. Earlier I used to do bimanual surgeries, but now with the unimanual with the single hand itself, it is quite comfortable. So this was one of the interesting case where I was trying to put the PFO and try to settle the graft around it. But as I kept on putting it, you can see here the graft moved up. Again I tried, I caught hold of it, removed the PFO, and again I tried to put it. Again it came up. So this happened multiple times, and one of my colleague, Dr. Giriraj, named it as a dancing graft. So finally I thought that okay, it was settling down, and I just tried to place it over the macular hole area. Then I tried to laser it, and while doing a fluid air exchange, now you can see the graft again started moving. Again brought it to the center. So this happened quite a number of times for me. Again you can see here it's again moving. Then again I had to do it, and then I realized that there was a small sheet of vitreous which was still left, and probably that was not allowing me to do that. And now you can see here, I thought okay, after doing this at least it will stay down. I thought okay, it's all going good, and did a fluid air exchange. And again if you see here, while removing it, again the graft started moving. Then finally I put the silicone oil. With the help of the silicone oil also you can see the graft moving here. So finally I thought I'll just complete the silicone oil infusion and then finally place the graft. But luckily it settled down well, and this is the post-op OCT. There is a type 1 closure in these cases. So this is some interesting, I just wanted to show that. So this is another 62-year-old diabetic patient underwent membrane surgery for PDR. So it was a simple surgery. So here you can see a 700 micromillimeter large hole. So the only thing what happened here was, while peeling this membrane, I just picked the vessel here. So it started bleeding, and I raised the intraocular pressure and put the PFO to control it, and then I went ahead and did a neurosensory graft because the ILM was already peeled in this patient before. So this is what I was mentioning about the unimanual technique, and then if needed you can always shift to bimanual. So I just slided the graft under the PFO. It was all looking good, but then you can see here it started becoming little more messier, is because the blood here got stuck there, and I thought whether finally I couldn't see the graft at all because it was embedded in the blood. So I thought just leave it, because the more we pull it, the blood here, the more the whole size is going to increase. But fortunately the autologous blood has also been used in most of these cases, and this is 1 month, and finally you can see the graft was placed well. It took up the graft well. So the next set is the new set of cases. We have done around 23 neurosensory grafts. This is the recent one where you have the ingenuity also with the NGF factor, the tissue detail. The important point what I want to make here is make sure that the graft what we take should be inside the cauterized area. Never take the area which is cauterized because that might contract after putting that. So this is the unimanual technique which I was mentioning about. Just with one hand also you can just try to cut the graft, and then after cutting it just leave a small hinge and then fill it up with PFO. And once you fill it up with PFO, then just try to place it. Just slide it under the over the mac hole, and then do a careful fluid air exchange. Most of the times these neurosensory grafts will not move at all. So this is the first week post of Dr. Vishal. You can see here there is a large mac hole but a good graft integration. Now coming to the question, the last video here, it had been operated for traumatic retinal detachment, but the patient developed RD here. So here again we did a neurosensory graft technique. Everything was going well. I just slided the graft, but unfortunately these PFO are becoming they break up into tiny bubbles even with a little turbulence. So here I saw that there was a small PFO which was bubbled. What happens is if we put the graft, the PFO still will definitely remain under. And then I realized under the macular lens or the flat lens that there was additional epiretinal membrane still there, stuck there. So then finally you can just place the graft easily, because ILM peeling was not possible in this case. ILM was already peeled in this case before. So what's the review? Large macular hole and autologous retinal transplant, a systematic review have shown that there is a recovery of the ellipsoid zone. External limiting membrane have been reported as contributors to the visual acuity improvement after surgery. So what's the topic behind this? It is the ectopic synaptogenesis, what has been described, means which involves the extension of the bipolar cell axons to form the new connections with the transplanted photoreceptor cells. And that is where in most of these cases of neurosensory graft surgeries, we are seeing that there is a visual acuity improvement in most of these cases. So this probably serves as a hypothesis like why there is visual improvement in these cases of neurosensory graft, and it also serves both as a scaffold and a plug, sealing the communication between the vitreous and the subretinal space. So in literature review there are various things listed about. You can do tanodiamond duster, that is a teasing technique, or the lens capsular flap, use of autologous platelets, heavy silicone oil, arcuate retinotomy. But finally I would like to say whatever best suits your hand and what best recovery or the surgical outcomes it's possible for you to give it to your patient, let's follow that. So with this, thank you very much once again for the patient listening. Thank you.
Great talk as usual, Dr. Joshi. What do you think in an already operated eye for macular hole? If you are just peeling the ILM, do you not think that the ILM peeling ILM is very difficult? Like it's quite sticky rather than normal ILM.
Yeah, you mean in cases where ILM was already peeled?
Peeled in the macular area, you are taking the ILM graft from
temporal area.
Temporal
yeah,
area.
the case to case basis it differs.
Yes.
In the myopic cases, definitely it's more difficult to get a single sheet. So the idea here is you need
patchy.
If you get small pieces, piecemeals, it doesn't work, because you keep on stuffing, and once you stuff it, there is a chances that you will touch the RP. Once the RP is touched, the game is over, because it becomes a scar. Although you can have a good anatomical improvement, but not a functional improvement at all.
Another thing, during the this ARG, autologous retinal grafting, you can use the DDMS or the Finesiflex loop to move it, to harvest the graft from that and slide it under the PFO.
So what we are doing here, sir, if you see here, I'm just catching the edge of that macular hole and then just slide it. I agree with your point. You can always do with the diamond dusted forceps also. If need be, we can do that. Otherwise, you just, it comes very beautifully under the PFO. It's just like sliding it up. Just slide it and leave it. It usually stays under the PFO because of the counter traction.
So all these cases of retinal autograft, you have used silicone oil as a tamponade, right?
No, the gas. The which I showed here recently operated was gas.
But some oil also.
Only if the patient says that I am not able to
Travel.
no,
Prone
do
position.
a prone positioning, only in those cases. Otherwise, gas works fantastic.
But
Gas literally works fantastic.
because what I use where there is no ILM is HAM, human amniotic membrane, and I think it is a less traumatic alternative to what you are saying, and the results are equally good. So, what is your experience vis-a-vis the visual acuity gain, or maybe the neurosensory development over that area, HAM versus retinal autograft?
Good question. I think that
It is less time consuming also.
there is a very good paper described by Stano Rizzo on where he has used a multiple of these and tried to compare it. Amniotic membrane, it just makes the anatomical closure. It stays there, and he has showed even the papers or the videos or the photographs where it stays for many months or years. It is just like a scaffold. It just scars up. It's just a tissue which plugs the tissue loss. But here what we see in these autologous retinal transplants is, it is the person's own retina which has the Muller cells, which has the glial cells. So what happens, the ectopic synaptogenesis, that means it is going to form connections with the remaining axons of the adjacent retina. That is where most of these neurosensory graft techniques have been shown to improve in the visual acuity. You see any paper, I just showed the meta-analytic paper as well, where it has shown that there is a good improvement. Restoration of ELM, restoration of ellipsoid zone has already been seen in these cases. So this will not be possible with the amniotic membrane.
But don't you think only the scotoma size decreases and whatever vision gain is there is because of some eccentric fixation?
Could be. That's what they call it as the ectopic synaptogenesis. But still we are seeing a visual improvement. I agree with your point that there could be an ectopic shift of the visual improvement, but we have not come across any patient who says that there is a scotoma or anything, because these patients usually have less visual acuity. They don't improve, but any 1 or 2 lines of visual acuity improvement in these cases, they usually appreciate it better rather than a dissatisfied multifocal with 6.6 or 6.5.
Thank you,
Just to
Dr.
make a small point,
Yes.
we have done around 10 of such cases. In the initial cases, what problem we faced, because we're trying to fix it, that in one of the case, I traumatized in the that macular bundle area, and after there was a development of CNVM in that case. Secondly, in the initial times, we don't used to take the graft, it turns to be smaller in size later on, contracted. Maybe the reason because we took it from the areas where we have done the cauterization. So over time, when we modified the techniques, we have seen that there is an initial plug formation at the site of where the retina adhesions are there, and over a year you cannot even make out that there was some graft there. Merges beautifully into the case, and that was a scenario. One case we had graft contraction, and in one of the case, because of the using that as the sir was saying, I used the diamond dust and traumatized actually that area, and there was a development of CNM. Those 2 experiences which I had in these cases. Thank you.
So just one comment. I think very nice presentation, very nice videos. I think this autograft which we are all discussing, I think these are probably we have to explain and counsel the patient that the vision gain will be very limited. So before going for a surgery, for these surgeries which are quite the outcome would be probably 1 or 2 lines. So you have to make them clear about the risk and benefit. I think every patient is not fit for this surgery, but I think the results are good with both AMG as well as with the retinal auto transplant. Yes. Results are good. Now regarding which one is better, I think we need more evidence, more data.
Evidence has already been published, sir. There are meta-analytic comparison between the amniotic. You can just go into the literature.
I think even Darius has also done a series of patients with AMG, and he is showing good results with AMG.
Yeah,
so
the good results,
both of them.
The good results is in the sense of type 1 closure of anatomical improvement.
Visual acuity.
The whole closure rates.
So anyways, the point is we're fighting for 1 or 2 lines of visual improvement. I think the conventional approach which you showed initially is very good. Is the best.
Of course, these we should not venture it initially.
And most of these cases already
these are the cases where the ILM is not available.
Yeah. And-
Only in those cases we try to do this,
And
not
in
in the
some of
cases
these
where-
cases, the RP is already atrophied. You know,
In those cases,
long-standing
they will not
macular
benefit.
Yeah, so in most of these cases, it is already. These are usually long-standing cases, 6 months, 1 year.
Actually, we are
So I
running
think,
out of time.
yeah,
so
we have to be very careful. Very nice presentation. So, but
Thank you, Dr. Joshi.